Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for the fifth episode of the Conversations in Interferon Gamma-Driven Diseases. During this last segment, we will be discussing some of the new developments in this field that were presented at the American Society for Hematology 2024 Convergence. I'm Dr. Alexey Grom. I'm a professor of pediatrics and a pediatric rheumatologist at the Cincinnati Children's Hospital Medical Center. I am joined by two of my colleagues, Dr. Ashish Kumar, also from Cincinnati, and Dr. Pui Lee from Boston Children's. Dr. Lee, could you please introduce yourself?
Yes, I'm Pui Lee. I'm a pediatric rheumatologist from Boston Children's Hospital, also assistant professor of pediatric in Harvard Medical School.
Dr. Kumar?
I am Ashish Kumar. I'm a pediatric hematologist, oncologist, bone marrow transplanter at Cincinnati Children's Hospital and professor of pediatrics at the University of Cincinnati.
Thank you. These are our educational objectives for the discussion today. We hope that after completion of this session, you should be able better to identify and differentiate the clinical presentations of various interferon gamma-driven diseases, including primary and secondary HLH, develop strategies for incorporating rapid point-of-care laboratory testing to expedite the diagnosis and treatment of HLH, analyze recent advances in therapeutic approaches in the management of interferon gamma-driven diseases, and integrate comprehensive care strategies in the management of this very challenging group of patients. As you probably know HLH is a hyperinflammatory syndrome driven by abnormal activation of T cells and macrophages associated with escalating production of cytokines, eventually leading to a cytokine storm. And over the last several years, interferon gamma has emerged as a pivotal cytokine in this cytokine storm as a potential therapeutic targets. Recent studies pointed to the diversity of potential triggers of both primary and secondary HLH, in addition to several inborn errors of immunity and infections. We also see HLH in association with immune abnormalities associated with malignancy, as well as transplantation, and more interestingly, now even pregnancy emerged as a potential risk factor for hemophagocytic syndromes. The condition is marked by significant morbidity and mortality, requiring early and precise diagnosis for timely intervention. The advances that were discussed at the ASH Convergence 2024 included some diagnostic innovations, some therapeutic advancements, as well as the identification of additional special populations of patients at risk for this complication. So, Dr. Lee, I will start with you. So what caught your attention at this meeting?
So there are many advances that we see in the diagnostic aspect of HLH. And of course, as a rheumatologist, I'm interested in secondary HLH as well, which we also call macrophage activation syndrome. So one of the very interesting abstracts is on EBV-associated HLH. As you know, EBV is one of the primary triggers of HLH as a infectious disease. And there's still a lot that we don't know about how this virus is so adept at triggering this hyperinflammatory response. And this happens both in healthy individuals as well as in individuals that have specific variants that make them more prone to this condition. So this is a study from Guangzhou, China. And what they did is a single-cell RNA-seq analysis of patients with EBV-associated HLH. So this is a really nice application of single cell technology, where you can actually look at the gene expression of every single cell type in the peripheral blood in this study. And you can both see the gene expression program of these different cell types, and also see what cells are actually infected with the virus, which is a tremendous advantage compared to some of the previous studies. As you may know, that staining for EBV is not simple, and to find what cells are actually infected could be quite challenging sometimes. In this study, they looked at patients with EBV and HLH. A single cell study involved, I think, 16 total patients. Half of whom have EBV associated HLH. And they look at different cell types and look at the transcriptomics of these cell types. And they found that, surprisingly, there are many cell types that are infected with EBV in these patients, including a small population of stem cells. And they looked at the profile of the immune cells, and in T cells, they found that these T cells have what they call exhaustion phenotype, meaning that these cells are spent and they're not so good at functioning as activated immune cells to help control infections. Along the way, they also see myeloid cells that have evidence of suppression. So this provides more evidence that in the context of EBV infection, there is an element of immune suppression where the body has inability to get rid of the virus, which then perpetuates this infectious process. They also provide some interesting evidence that EBV viral load actually goes up before a flare of HLH, which shows that these in HLH in these patients is clearly driven by EBV before the flare. So I think this sort of adds a lot to what we know about EBV-induced HLH, at least a lot more specificity in terms of the cell types that are involved and type of immune response.
Dr. Lee, my understanding that the type of immune cells infected with EBV very much depends on the ethnic background. And certainly the infection of T cells, direct invasion of T cells with EBV is much more common in the Chinese population. Dr. Kumar, is it correct? Is it your experience?
Yes, that has been our experience, that we see quite a few patients nowadays referred to us with EBV HLH, and we find that the EBV is in the T cells or NK cells, and majority of these patients are of East Asian ethnicity, China, Vietnam, Thailand, Laos, Cambodia, but not exclusively. That is the most common ethnicity. The second most common is native Pan American, so native North American, Mexico, South America, people who are native to the entire Pan American land are also prone to get EBV in the T or NK cells. And very rarely we see it in Caucasian people as well. But the majority of the patients we see are ethnically from East Asia, specifically, China. We see quite a few patients whose ethnicity originally is from China.
Yeah, that brings up a really
interesting to see whether this could be extrapolated to the Caucasian population, correct?
Yeah, absolutely.
Yeah. And that brings up a good point, how EBV can do so many different things, right? In the acute infection, it affects mostly B cells. It can certainly cause malignancy, and when it stays in T and NK cells, it seems to drive this phenomenon in susceptible populations.
Right, and this actually has some very critical therapeutic implications, because it's just coincidental or serendipitous that if we use checkpoint inhibitors that prevent the exhaustion of T cells through the PD-1 ligand PD-1 receptor interaction, that seems to get rid of the EBV and the HLH in these patients. So that discovery was made before this abstract came out, and so it's a little backwards, but it actually makes perfect sense now, because and the first paper that suggested that actually also came from China. I'm not sure if it's from the same institution, but several years ago in Blood, and that prompted us. So we have now started using checkpoint inhibitors in these patients as a therapeutic strategy, and we are having tremendous success. And this was our hypothesis. We wondered, is it because somehow these patients have their T cells are exhausted, which is why they cannot attack the EBV infected cells or cannot get rid of the EBV infected cells. And lo and behold, that may be true. Now, why is it that this happens only in this certain ethnic populations and not the others? What's the key to that is something that I don't think any of us understand.
Fascinating. All right.
Absolutely fascinating. Yeah, but there is a paper that also suggested that EBVs in the stem cells in these patients, and that was the rationale for us using stem cell transplant for this disease. And so now it remains to be seen. We have now cured, I put it in quotation marks because it's been a recent therapeutic approach of using checkpoint inhibitors. Does that get rid of the infected stem cells as well? Don't know. Remains to be seen.
All right. This next abstract is titled "The Self-Supervising Learning Model for HLH Diagnosis." So this brings in an element of artificial intelligence and imaging recognition for HLH diagnosis. And as you all know, right, diagnosing HLH, the guidelines are imperfect. And part of the HLH 2004 guidelines involved the diagnostic feature of hemophagocytosis, right, which is a marrow in the feature in the bone marrow that we often see with large macrophages internalizing other elements of the blood, like such as red blood cells and white blood cells. And if we see that, that's fairly pathognomonic in the context of HLH and MAS, but not completely, because we can also see some of this in other conditions as well. And there's also sometimes difficulty about spotting these cells in the marrow, right? Because it's such a large field, and to find a few of these cells may not be easy. And the location of the biopsy and the quality of the specimen are also very important. So in this abstract, the authors use this approach for machine learning and looking at bone marrow biopsy slides from patient HLH, I think 20 some patients with HLH, and a whole host of other conditions that involves bone marrow abnormalities, including those with malignancy and those that are relatively normal for staging of various malignancy, looking for remission and things like that. And so they use this machine learning to look at features that are common or different across the different diagnoses. And they were able to find 45 different tiles, which are sort of characteristics that are different among them. One of these tile was higher in the HLH group, and 7 of those are lower in the HLH group as sort of a diagnostic feature relative to the other comparator groups. And the one group, the one tile that is enriched in the HLH group are these elements that will look like hemophagocytosis. So macrophages with internalized erythrocytes. So makes sense. And this seems to work very well when they use area under the curve analysis to see how well does this method distinguish HLH biopsy compared to those of other diagnoses. And we're looking at area under the curve of upwards of like 98% for some of these comparisons, and at least 90%. So it seems like a very interesting advance that perhaps can help automate things and make it takes out at least some of the subjectivity in making a diagnosis of HLH. What do you guys think about this?
Well, in my clinical practice, I looked at lots of bone marrow biopsies from both primary and secondary HLH. And another striking feature that is very consistent between those biopsies is a massive expansion of activated CD8 positive T cells. And it makes perfect sense. We believe that HLH is a T cell driven phenomenon. I'm very surprised that this particular approach did not pick up this feature as a diagnostic way to distinguish HLH. I'm very puzzled with that.
I think some of that depends on what their controls were, because if they were using lymphomas and MDS, if many lymphomas actually have activated T cells associated with the lymphoma cells. In fact, in many lymphomas, if it's a B cell lymphoma, such as Hodgkin's or even non-Hodgkin's lymphomas, in the biopsy, majority of the cells actually are activated T cells that are there to try and get rid of the B cell lymphoma. I'm using Hodgkin's lymphoma as an example, but this is true for many other ones. So perhaps expansion of activated T cells is a feature that may be common to lymphomas and HLH. And that's why perhaps it did not distinguish. But that's one possibility. There could be other ones. Of course, what intrigues me is the fact that there may be morphologic features that the machine can pick out that the human eye has not recognized yet. And I know on the tiles that we're showing here, and I don't have the detailed description, so I'm guessing that they're focusing mostly on activated macrophages with phagocytized cells, which is a feature of the syndrome of HLH. Unfortunately, it is also a feature which they do not include here, is every patient with the infectious mononucleosis will have activated macrophages showing hemophagocytosis. Now, we don't normally do bone marrow biopsies on such patients, but I have seen a few in my career because that is what was suspected. Then we eventually found out, no, it was just a case of mono, but you see florid hemophagocytosis in that situation. And so many of these patients will fulfill the other diagnostic criteria, features, whatever you say, the HLH 2004 or the H score. And all they tell you is that the patient has the clinical descriptive manifestation of HLH. It doesn't tell you what's driving the HLH. And that is where I will put this. This is another tool to make the clinical description fulfill the description of HLH. I don't want to take too much of a segue, but I think in our field, this is the most critical step. We need to look beyond the description of HLH, because that is what is key to decide what do we do next. The challenge is that if all you do is it tells you, yes, this patient has HLH, well, yes, I'm not saying that is not a novel way of doing that, but what we need are tools to tell us, well, what do we do next? So while this may be very informative, we need to recognize that that's how far it goes. It helps us perhaps in a less human error prone way of getting to the description of HLH.
Yeah, I think probably provides more sort of uniform assessment of these biopsy, and it reduces sort of inter-rater dependency and those type of
Right. And again, they use MDS and lymphoma as the negative controls. We see there are many other conditions that many lymphomas and many other diseases we see in children, quite a few that have a histiocytic hyperplasia associated with them. And whenever that happens, you will see florid hemophagocytosis. And I used mononucleosis as one example, but there are many other conditions that can do the same thing. And those would then probably, I don't know, I'm guessing that those might fulfill the definition of HLH according to this AI tool. Because with all these algorithms or AI tools, they're only as good as the data that we feed it, right?
Yes. All right, so another method to look at HLH, right? So this abstract looks at the utility of PET scan, PET CT imaging in patients with malignancy associated HLH from a study from Dr. Prakash and colleagues from MD Anderson. So, PET CT, we often use that as an imaging modality to look for malignancy, right? Looking for cells and tissue that have lots of metabolic activity based on this tracer dye uptake. And so that's sort of a well-known approach to look for malignancy or a recurrence malignancy that may be hiding somewhere and be able to spot that. There are some studies for HLH that have shown that there are features that you can see in PET CT, including hepatosplenomegaly, a lot of activity in the spleen and liver along those ways, and diffuse activation in the lymph nodes. None of these, of course, are a specific feature of HLH. So this study looks at malignancy associated HLH, which is again another key trigger of HLH, particularly in adults. Many types of malignancy can be associated with HLH, and when we see HLH in the context of malignancy, the mortality is often quite high, and they're often difficult to treat, even with a lot of the available immunosuppressive agents that we have available. So this study looks at a group of patients with malignancy-associated HLH, looking at a window where they've gotten PET scan around the time of the malignancy-associated HLH diagnosis, and see if findings on PET scan, what they call positive finding, meaning then they find areas of uptake, is correlated with either laboratory findings or outcome of HLH in these patients. So sort of intriguing idea to see if you can have sort of a non-invasive way, right, of looking at HLH activity in this dangerous condition. And so most of the findings were actually negative, unfortunately. But this is rather important, though, right, to understand the limitation of some of these approaches. And what they find is that they do see a significant portion of patients that have uptake, what they call positive HLH. And when they compare those patients with the signal compared to the patient without the signal, they actually did not see many differences in the biomarkers, including ferritin levels and a number of cytokines that they have in the cytokine panel. And more importantly, this positive uptake in PET-CT did not really show differences in terms of survival in these patients. So an interesting idea to bring in a imaging dimension to diagnose HLH in the population that were malignancy associated complications. But there's clearly limitations of this technique also, and it doesn't seem like there's tremendous advantage, I guess, over some of the biomarkers we have available at the moment, but perhaps it can be used as complement to some of these approaches.
Yeah.
Your thinking as well.
Yeah, Dr. Graham, what do you think?
Yes, I was going to say that we pediatric rheumatologists often deal with patients with systemic juvenile idiopathic arthritis, a condition where we often see secondary HLH or macrophage activation syndrome. And when we start with this initial diagnostic workup, usually malignancy is somewhere on the top of the differential diagnosis. And more and more physicians actually perform a PET-CT scan with the goal to rule out malignancy and confirm the diagnosis of systemic JIA. And I can tell you that all those studies have been very disappointing. The spatial distribution of the uptake really does not distinguish between even systemic juvenile idiopathic arthritis and malignancy. I think, although we still do it, in general, in clinical practice, I don't find it very helpful, even in systemic JIA, which is much less inflammatory syndrome than HLH.
Yeah, I agree. I mean, it is important, especially in adults who are manifesting the features of HLH without anything else. And if they don't have a diagnosed malignancy, I think a PET-CT is critical to help diagnose the malignancy that is driving the inflammation. We often find that physicians, they didn't consider malignancy as a possibility because in many clinicians' minds, HLH is a conclusive diagnosis in itself, whereas in reality, it is a manifestation of an underlying illness that is causing systemic inflammation. And MAS in the context of systemic onset GIA or adult onset Still's disease are the ones that you guys, rheumatologists, are most familiar with in the non-rheumatology world. In adults, particularly, we find that malignancies are one of the most common drivers of HLH, and a PET scan is absolutely critical in making sure that we have ruled out a malignancy, or if we do see FDG avid lesions, that we confirm what that malignancy is. And I think these authors tried to see beyond that, are there other ways in which the PET scan could be utilized to then help create prognostic markers or predict the outcome? And I don't think it did, because obviously those who did not have a malignancy, or even those who did, the PET signal, I don't think tells you what the outcome will be when it comes to the HLH part. So real quickly, we'll review some of the therapeutic advances in HLH abstracts that were presented at this year's ASH meeting. And this one is particularly interesting. It kind of dovetails into the conversation we were just having regarding malignancies and in adults. And so a couple of years ago, some of my colleagues, our colleagues, Doctors Jordan and Dr. Lorenz, Zoref Lorenz from Israel, they have extensively studied patients with malignancies, hematologic malignancies, who fulfilled or who had features of HLH, and they did a little more deep dive look into it, and they recognized that in addition to just fulfilling the HLH 2004 criteria, there were specific features that distinguished those patients whose inflammation was beyond what was expected in lymphoma, because this is the challenge that patients who have lymphoma will often fulfill the HLH 2004 criteria. Is that because they have HLH, or is that because the HLH 2004 criteria lack some specificity that they will be fulfilled by patients who have lymphomas? And so what they found is that within patients with the hematologic malignancies, beyond just fulfilling HLH 2004 criteria, there were certain markers that distinguished these patients who had inflammation beyond that was expected, beyond expected in a hematologic malignancy such as lymphoma. And these patients' outcomes were poor, and they labeled this group of markers as the optimized HLH index, or optimized hyperinflammatory index, called OHI. So this particular abstract from Dr. Davar et al. Again at MD Anderson, they said, the OHI has only been described in one group of patients. So they took their group of patients, majority of them with hematologic malignancies, and said, okay, these are the patients who, and they identified those patients who fulfilled the HLH 2004 criteria, and then they applied the OHI index, and then they also looked at patients who did not have HLH at all, so they just had heme malignancies, and compared the distribution of the markers, what we call the regular HLH markers, that is the HLH 2004 criteria, and then the OHI markers to see which ones correlated better. And they found that even in this limited population, at a totally separate population than what was the original description of the OHI index performed better in identifying those patients who had more inflammation and worse outcomes compared to the standard HLH markers. So this was a nice validation of the OHI in a fresh population altogether. And then they went one step further in a very small number of patients who had malignancy-associated HLH. I think in 6 patients, they treated them with emapalumab, the monoclonal antibody that targets interferon gamma, which, as in the introduction, Dr. Graham pointed out that in all forms of HLH, both primary and macrophage activation syndrome, interferon gamma seems to be the key player. And they treated a handful of patients with emapalumab, and they showed data that their inflammatory markers did go down. I don't think there's enough data for us to say here that emapalumab actually reversed the outcome, because the outcome data probably were not included. But at least that is one therapeutic approach that potentially may be helpful, at least reduce the inflammatory markers. And from that, one can extrapolate that if the inflammation came under control, perhaps the patient's outcome would be better as well. But for that, we do need the longitudinal outcome data that I don't think was not available. So sorry, I had to give a lot of background in order to explain what these guys were doing. So that was this abstract. Dr. Lee or Dr. Graham, comments or thoughts on that?
I think it speaks to the central biology of interferon gamma in HLH as a syndrome, right? Not rather an individual entity that we've seen in hemonc or rheumatology, but it seems like it's the central axis that this really emphasizes that point. Sort of this treatment blocking this axis seems to, at least from a biomarker standpoint, reverses some of the key features.
Right.
Looks to the HLH also. Yeah.
Yeah.
It also reinforces the idea of how important you have a CXCL9 as a clinical test at your center.
Completely agree. I couldn't agree more. Yes, because these are some of the things I know that the HLH 2004 and the H-score use simplified markers that are universally available, but unfortunately, in this day and age, those are not sufficient because we have learned so much more about these entities. I think in order to truly manage HLH, real HLH properly, you really need CXCL9. Without that, we truly are flying blind in knowing, are we actually dealing with real HLH and are we actually controlling the disease? So yeah, okay. This was a pediatric study, the real HLH study, looking at the I wouldn't say that the impact, but the outcomes of patients who received emapalumab, HLH patients who went on to transplant, those who received emapalumab. Now, it started off with a larger group of patients, but by the time we get to how many patients got emapalumab, and of those, how many got to transplant, the numbers actually dwindled because they only had a total of 35 patients, of whom only 29 had primary HLH. And not all of them got emapalumab. And those who did get emapalumab, some got it actually even during their preparative conditioning regimen, and some got it even after the stem cells were given. But overall, the outcomes of this study show that the overall survival and the event-free survival, that is, challenges that they had after transplant, did not seem to differ too much compared to historical controls when it comes to adding emapalumab. So, 75, close to 74% of the patients had overall event-free survival, and 50% had intervention-free survival. That means they did not need a second transplant or a stem cell boost, because in patients with the primary HLH, mixed chimerism continues to be a big challenge, because we end up having to use less than full myeloablative conditioning, because these patients historically have not tolerated full myeloablative conditioning. So in order to save their lives, we have used slightly less. There are a couple of different ways of doing the less than full myeloablative conditioning. And that ends up then resulting in mixed chimerisms, which sometimes requires a second transplant, sometimes requires other interventions, but not always. But the addition of emapalumab definitely did not make these numbers worse. And so that's what this poster showed. Dr. Lee, Dr. Graham, thoughts?
Yes, I was expecting to see improvement compared to the historic controls.
Yeah.
It doesn't seem to be the case, correct?
Not from these data, but I will also tell you that, some of the, and again, I don't have the details of the granular data of all the preparative regimens and how many doses of emapalumab they got, how many patients got emapalumab closer to transplant. Most of these patients, the inclusion criteria was that they had to have received at least one dose of emapalumab. So potentially some patients only got a single dose sometime during their transplant journey. So it's a little hard to tell. However, although not in this abstract, there is a recent paper in Blood from our center, from Drs. Jordan and Dr. Verkamp. Dr. Bethany Verkamp is the first author. And at least, and it's a little more uniform data set. In those patients, those who got emapalumab, tended to have fewer incidents of mixed chimerism after transplant compared to those that did not get emapalumab. So yes, this was a little surprising, but I think the numbers here, and because it's a mixed population, I'm not sure we can draw too many conclusions quite yet. That paper that just recently got published in Blood has a more uniform and a larger population, and there were enough numbers in there to signify that addition of emapalumab prior to transplant resulted in fewer mixed chimerisms post-transplant.
I think I recall another paper from Franco Locatelli in Italy that was actually very supportive of the idea of using emapalumab around hematopoietic stem cell transplantation with a dramatic reduction in the exposure to some toxic drugs. So I think if you look at the literature, the data does support the use of emapalumab.
Did this author mention sort of improvement in some of the associated markers like CXL9 and
No, I don't think so, because I don't think they had those data in all of these patients. Yeah. So that is one of the limitations, that it's a little bit of it's a small data set. They started off with a large number of patients, but by the time they get to how many got emapalumab, how many made it to transplant, the numbers are too small, and it's spread over a larger number of institutions. So it's a little bit of a heterogeneous data set. So it's hard to draw too many conclusions, other than the fact that it appears quite safe and feasible. Whether it is favorable outcomes, I think for that we will need the other publications that we've just mentioned. This is actually a literature search. These authors searched the literature for collecting all the reports of where HLH was reported in during pregnancy, and then what were the triggers. And so they found that infections were quite common, EBV, CMV, and then autoimmune diseases and malignancies. So these are all the same triggers that we regularly encounter even in the non-pregnant population. And they found that the similar ones were seen in even in pregnancy. The same triggers can result in HLH. Now, the challenge, of course, is when you're dealing with a pregnancy, the treatment becomes very tricky. And so they report that in majority of patients, steroids were utilized, which makes perfect sense. But then they also reported the use of HLH94, basically etoposide-based during pregnancy, which is a huge risk to the fetus when you're exposing a fetus to a chemotherapy cytotoxic agent like etoposide. Now, they also, in a small number of patients, they also used anakinra. And unfortunately, again, the details are not known because this was more of a literature search. So the granular details data are not available. But unfortunately, there was a significant mortality rate of 18%, and pregnancy loss also close to 50%. And now, interestingly, the HLH itself in the pregnant patient reversed upon delivery. And so, yes, that caught my attention too as well. Like, how does that happen? So I don't know. I've been trying to speculate and hypothesize. We routinely think of pregnancy as an immune suppressive situation, but clearly in some circumstances, perhaps the pregnancy was inducing autoinflammation, and that reversed once the fetus was delivered. I have to admit some of my bias, because how did they define HLH in all these publications? And majority of them, they define it either by fulfilling the HLH 2004 criteria or the H score, and perhaps sometimes people just diagnose HLH based on the presence of hemophagocytosis on the bone marrow biopsy. Now, the fact that somebody would do a bone marrow biopsy in a pregnant individual, that would make me think that there must have been something seriously wrong clinically. So one can extrapolate that. But interesting description. particularly the one that the HLH reversed upon delivery. I found that fascinating.
The other thing I noted is that you're absolutely right. In most of these patients, they did observe traditional triggers like infection, autoimmune diseases, or malignancies. But my understanding that about 40% of these patients actually did not have any triggers, despite a very, very rigorous search for the triggers, suggesting that maybe immune dysregulation associated with the pregnancy itself is a sort of additional risk factor for HLH. To me, it's interesting from a very different perspective. Again, going back to macrophage activation syndrome that we see in patients with systemic juvenile idiopathic arthritis. If you think about the underlying disease, the male to female ratio is 50-50. So that's one of those rheumatic conditions where really gender doesn't matter. But when you look at the patients with macrophage activation syndrome, we certainly see some female predominance.
Yeah,
I would say 60-40, maybe even a little bit high in some populations. Again, suggesting that although for the underlying disease, the gender probably doesn't matter, but for the secondary HLH as a complication of this disease, it seems to be that it does. So I'm wondering whether some of the findings in this particular study would be relevant to what we see in patients with macrophage activation syndrome, the hormonal background that somehow tilts the overall balance towards this hyperinflammation.
I also sort of wonder whether some of the pregnancy complications, I mean, a lot of them are the immunologic basis, a lot of those are not really well known.
Exactly.
Like HELP syndrome, for example, right? We think about liver involvement, coagulopathy, low platelet.
Exactly.
You know, that looks a bit like cytokine storm, you know, in our settings.
It absolutely does. And that was my concern as well, that perhaps we are calling it HLH, but in reality, the true driver, I don't know, because we don't have, you know, CXCL9s or IL-18 or anything like that. But, you know, in those patients, and if we're talking about those patients in whom we did not identify a trigger, what was the cytokine? Was it CXCL9 or not?
Right.
And if so, or was that actually an extension of some other underlying immune dysregulation, which is what I suspect underlies things like HELP syndrome, and it just, you know, bleeds into a little bit of the features of HLH. Again, we can speculate all we want, but I think there's a lot more that we don't know about the immunology of pregnancy.
I'm also so curious about the fetal side of things, right? All these cytokine storm, what happens to the other side?
Yes, yeah.
I guess we already touched on pretty much all these points. I think the artificial intelligence-driven tools do show the promise, but I don't think we are there yet. I think that clearly I think the role of the biomarkers such as CXCL9, IL-18, and the soluble IL-2 receptors, it's indisputable. I think it's very important that all the centers have these biomarkers available as a clinical test. I think there is a bit of a problem of if we use different kits, whether the question is whether the numbers could be comparable between the different centers. I think there is a clear need for some kind of standardization of the kits that we use to measure those biomarkers. And clearly, if we do it properly, we certainly can come up with a sort of a very individualized approach to the treatment of hemophagocytic syndromes in general. I think we need to probably touch the idea of international registries, right? I think it remains very, very relevant, particularly for, as an example, the HLH associated with pregnancy. I'm sure it's exceptionally rare. There is no way we can approach this particular topic without international collaboration, without good quality international registries. And I think in conclusion, we would like to kind of summarize some of the key takeaway points on interferon gamma-driven diseases from the ASH 2024 meeting. In terms of diagnostic innovations, I think the artificial intelligence-based analysis does show a promise for diagnostic precision, but I think we are pretty far from the implementation of these approaches in clinic. PET scan imaging seems a bit disappointing. However, if you combine this with the optimized HLH inflammatory index, it could be used as a sort of a measure of HLH severity. In terms of therapeutic advances, I think emapalumab indeed shows a promise in refractory HLH as a bridge to hematopoietic stem cell transplantation. We did not discuss it much, but it looks like reduced intensity conditioning regimen is the way to go. I think it's accepted more and more by most of the centers around the world. And I think there were several posters at the meeting that certainly would support this idea. The HLH in pregnancy, again, I think it's very perplexing. And again, I think it's a phenomenon that needs to be studied. And it's certainly, to me, again, as a pediatrician, I think it may help understand the predominance of females with MAS in our patient population. And in terms of future directions, I think we all agree there is a clear need for simple panels of these reliable diagnostic biomarkers that are available immediately at each center that deals with this patient population. So I think that's probably it. I would like to thank the audience for the interest in this particular topic, and thank you.
Thanks, Dr. Graham. Thanks, Dr. Lee.
Thank you, Dr. Graham.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.